Well, this week's Cardiology Countdown is all about risk stratification. First up, we have risk stratification applied in the Barry 2D trial that looked at patients with diabetes and coronary disease to see how to manage them. Patients were randomized to medical therapy or revascularization. And this particular analysis applied angiographic and clinical risk assessment in those who were randomized to between either medical therapy and bypass surgery. And they included angiographic variables of extent of disease, number of lesions, and ejection fraction, and reaffirmed, I think, what has been thought for years from the old CAD study, that patients randomized to CABG who had extensive coronary disease or LV dysfunction had significant improvement in survival with CABG, with the rate going from 36.8% down to 24.8% amongst the higher risk group. So I think modern data reaffirming something that we've been practicing for a while. Next up, we have risk stratification applied to atrial fibrillation. This uses the new CHADS-2 VASC score to further risk stratify the CHADS-2 risk score 1 patients, which are generally low risk, and guidelines are starting to suggest anticoagulation in the CHADS-1 group. So they applied the CHADS-2 risk score, CHADS-VASC score, that adds additional gradation for age, counting an increased risk factor between age 65 and 75, also female gender, and prior MI or known arterial disease. They found when doing that, having a CHADS-VASC score of 2 or higher identified that subgroup amongst the CHADS-1 that were higher risk than those who had both CHADS and CHADS-VASC scores of just 1. So they suggest that very low-risk group may not need anticoagulant therapy. I think a caution, however, that this has to be looked at within the randomized trial, because even within the group of CHADS 0 and 1, there appeared to be the same roughly 50% benefit of apixaban versus aspirin when studied in the Averroes trial. So future data coming on that score. And then finally, a big analysis of C-reactive protein and fibrinogen in patients without known vascular disease. This was the Emerging Risk Factors collaboration that looked at 52 different prospective studies. They found that looking at the C statistic, there was a very small but significant increase in the C statistic when adding either HDL as sort of a control of 0.005 increase in the C statistic. And for fibrinogen and CRP, it was 0.0027 and 0039. They estimated then that if you added CRP and fibrinogen to current guidelines, which would then identify patients within the high-risk group that would be recommended to receive statin therapy, that one could prevent one event over a 10-year period for every 400 to 500 patients screened with these two new markers. This is additional risk stratification that some will debate whether that's worth it or not. So for this week's Cardiology Countdown, I'm Chris Cannon.